Mental Health Trilogy, Episode 3, Anxiety and Depression. Too wired to stop, too drained to move. Opening. One person, two warning lights. If you watched the first two episodes, you may have noticed something awkward. Anxiety and depression keep borrowing each other's symptoms. Poor sleep, fatigue, irritability, trouble concentrating, social withdrawal. CBT appears in both treatment plans. SSRIs appear in both medication lists. So are these two different conditions, or one condition wearing two outfits? And why can one person spend a day chased by anxiety and a night pinned down by depression? It can feel like pressing the accelerator and the brake at the same time. You do not get very far. The system just overheats. In this final episode, we are putting anxiety and depression on the same map. Where they overlap, where they diverge, and how they can keep each other alive. Part 1. Co-occurrence is common. The short answer is that anxiety and depression often coexist. The exact numbers change by study, population, and definition. But in clinical samples, the proportion of people with depression who also meet criteria for an anxiety disorder is often around half and sometimes higher. Anxiety disorders also increase the risk of later depression. Researchers use the word comorbidity when two or more diagnosable conditions occur in the same person. That word can make it sound like two strangers happen to sit at the same table. Anxiety and depression are more like frequent collaborators. When they appear together this often, the useful question is not only, which one do I have? It is also, what do they share at the root, and how does one feed the other? Sometimes the path from one to the other is simply alarm for long enough. Part 2. Shared foundations, not one magic switch. There is no single anxiety and depression switch in the brain. Their overlap is layered. First, they share some genetic and temperamental vulnerability. One example is neuroticism, a tendency to experience negative emotion more readily and to respond strongly to threat or frustration. It is not a flaw and it is not destiny, but it can increase risk across several internalizing disorders. Second, both interact with the stress response system. Chronic stress can affect the HPA axis, sleep, hormonal rhythms, and immune processes. Anxiety can keep the body prepared for danger long after preparation is useful. Third, they share cognitive habits. Anxiety tends to overestimate threat. Depression tends to underestimate hope, reward, and personal capacity. Both can involve rumination, negative attention bias, and avoidance. These shared roots also produce a shared direction of travel. Anxiety shrinks life through avoidance. As work, relationships, sleep, and confidence erode, depression may become more likely. That pathway is not inevitable, but it helps explain how always on can eventually become nothing left. Part 3. The memorable difference. Direction in time. If you want one useful distinction, try this. Anxiety points toward the future. Depression often traps a person in the present or the past. Anxiety's native language is, what if? What if I fail? What if I get sick? What if they reject me? What if I cannot cope? Its energy is activated. Racing heart, tense muscles, endless mental rehearsal. The energy is real. It has simply been hijacked by a threat that has not happened. Depression's language is closer to what is the point, not as a calm philosophical choice, more as a collapse in the capacity for possibility. Pleasure is distant. Action is heavy. The future looks unavailable. One resembles an alarm system on overdrive. The other resembles a power grid running at minimum capacity. But metaphors are not diagnostic formulas. Real people can be frightened and exhausted, agitated and numb all at once. Mental health rarely enters a room in neat textbook order. Part 4. Same symptom, different texture. Take insomnia. With anxiety, the mind often keeps sprinting. What happens tomorrow? What did that message mean? What if the worst-case scenario is the real one? With depression, sleep may also be difficult, but the pattern can include early morning waking or sleeping far too much and still feeling drained. Now fatigue. Anxiety fatigue is what happens when the engine has been revving for hours. Depression fatigue can feel like the engine will not turn over at all. Concentration problems also have different textures. In anxiety, attention is repeatedly stolen by threat. You're trying to work, but the background keeps launching pop-ups. In depression, thought may feel slowed. Working memory can feel smaller. Even minor decisions load forever. Social withdrawal? Anxiety may avoid people because of judgment, embarrassment, scrutiny, or panic. Depression may withdraw because there is no energy, no pleasure, or no sense that showing up matters. Irritability deserves attention too. Anxiety can make the nervous system feel wound too tight. Depression can also present as irritability, especially in young people, rather than quiet sadness. Part 5, which came first. There is no single script. Anxiety often begins earlier in life. Many anxiety disorders, particularly specific phobias and social anxiety disorder, commonly begin in childhood or adolescence. For some, like generalized anxiety disorder, onset can be later, but across the anxiety disorder family, earlier onset is more typical than for depression. Over time, chronic worry can produce avoidance, poor sleep, strained relationships, and a repeated sense of losing control. When every day feels like a threat you cannot solve, hopelessness can grow. The alarm has been ringing so long that the system becomes depleted, but the arrow can point the other way. Depression can reduce confidence, energy, and problem solving. Tasks pile up. The future becomes harder to manage. Anxiety rises. The two can form a loop. Anxiety ruins sleep. Poor sleep worsens mood and concentration. Low mood increases avoidance and procrastination. The growing backlog gives anxiety fresh material. Sometimes treatment stalls because only one half of the loop got a name. The other half keeps running. Addressing both is not about collecting two diagnoses. It is about treating the whole system. Part 6. Why some of the same treatments help. Here is the question we planted in Episode 1 and returned to in Episode 2. Why are SSRIs used for both depression and several anxiety disorders? Not because the two conditions are identical, and not because both are simply caused by low serotonin. A better explanation is that they partly share systems involved in emotion regulation, threat learning, stress response, and neuroplasticity. A medication that changes those regulatory systems may help symptoms across more than one diagnosis. The same drug does not mean the same dose, timeline, side effects, or response. Therapy overlaps in the same way. CBT is used for both, but the target can differ. Anxiety treatment often focuses on catastrophic prediction, avoidance, safety behaviors, and exposure. Depression treatment often emphasizes behavioral activation, hopelessness, self-criticism, and rebuilding daily rhythms. When both are present, there is no universal rule that one must always be treated first. Clinicians prioritize safety, severity, functional impairment, and whatever is blocking the person from engaging in treatment. Part 7. A useful model. Shared distress, different features. A framework called the tripartite model, proposed by psychologists Clark and Watson in 1991, offers one way to describe the overlap. It may also help explain why some treatment strategies can be useful across both conditions. Anxiety and depression both involve elevated negative affect. Distress, irritability, discomfort, and emotional pain. Depression is more strongly marked by low positive affect, reduced pleasure, interest, and energy. Anxiety is more likely to include heightened physiological arousal and threat response. The model is not a final answer, and it cannot diagnose anyone, but it explains why two people may both say, "I feel terrible," while the internal architecture of that suffering is different. Modern research increasingly looks across diagnostic categories. Instead of asking only which box a person fits, clinicians and researchers may also ask, how strong is threat sensitivity? How low is reward response? What is sleep doing? How much rumination and avoidance are present? This does not make diagnoses useless. It simply admits that a human being is more complicated than a table of contents. Part 8. When to get help. If you have both anxiety and depression, do not turn that into a story about failing twice. Comorbidity can mean more complex symptoms and a slower course. It still responds to treatment. A few questions can help you describe what is happening. Am I mainly anticipating danger? Or have I lost interest in pleasure? Am I awake because my mind is racing? Or am I waking early, oversleeping and feeling leaden? Am I avoiding people because I fear judgment or because I have no energy and cannot see the point? How long has this lasted, and what parts of life have changed? That information is more useful to a clinician than "I have just been off lately." If there are suicidal thoughts, a self-harm plan, an inability to stay safe, or symptoms so severe that eating, drinking, sleeping, or basic self-care are breaking down, seek urgent help. In the United States, call or text 988. Elsewhere, contact local emergency or crisis services. Safety comes first. The exact label can be sorted out afterward. Outro, not 2 boxes, 1 map. After 3 episodes, here's a map. Anxiety is a protective system over-predicting danger. Depression involves mood, reward, and action systems shifting toward numbness, reduced pleasure, and depletion. They are different, but they share some risks, symptoms, and regulatory pathways. They can also strengthen each other through stress, avoidance, poor sleep, and the consequences of a life that keeps getting smaller. So it may be more useful to picture overlapping territory than 2 sealed boxes. Some people live mostly in the alarm zone. Some live mostly in the low power zone. Some stand at the border. Too frightened to stop and too exhausted to move. Naming the experience is not about collecting a more complicated label. It is about finding help that actually fits. A name is not the end of the story. It is the point where the conversation can finally begin. That brings our mental health trilogy to a close. The earlier we can name what is happening, the sooner we can stop carrying it alone.